Varicoceles obviously are dilated veins, like varicose veins, and they occur often quoted in men who have infertility, although if you look at the literature, they can be seen in many, many men, and there is a crossover here in just varying studies. What I think is important is to define varicoceles as to whether they are primary or secondary, and the secondary are acquired varicoceles. By primary, I mean people who have problems with incompetent veins, such that the drainage through the spermatic vein is deficient and you end up with stasis of blood. Now this occurs typically on the left side because of the negotiation of the left spermatic vein into the left renal vein, making that sharp left-handed turn. That seems to be difficult in many cases, and you have, with associated incompetent valves, you develop dilated veins in the scrotum on the left side. The right side is not as difficult to negotiate the returning blood through the spermatic vein because of the oblique course directly into the inferior vena cava in most men. So since you have a direct flow into the central vasculature of the renal vein or the IVC, when you have these primary varicoceles, if you will, you should see change as the patient valsalvas or assumes an erect position. In those situations, you will see change within the varicocele. With an acquired or secondary varicocele, there's a frank obstruction, either at the level of the renal vein or at the level where the right spermatic vein joins the inferior vena cava. And then, because there's a frank obstruction, you do not see those changes with various maneuvers, including Valsalva or change in the patient's position. And here are just some examples of the location where varicoceles can occur. They can be at the level of the cord. They can be anywhere within the scrotum, so you have to look carefully. Here we have one that's entering the testis, small. You can see it often with color flow. Here you can see the enlargement as the patient assumes an erect position. Here you can see slow flow. You must, if you're going to use color, adjust your settings to a slow flow parameters. But you really need to have color. Here you can see just with a clip. Just with a clip, you can see, if I come back to that clip, you can see flow. All you have to do is turn your gain or volume control up on your grayscale and make the image large. And the slow flow assumes that the red cells are going to clump together in what's known as rouleau, and you can see it. And sometimes you can't see it with color at all because the flow is so slow. So these clips are nice to show you varicoceles. By that we mean 3 millimeters or so or greater, or clumping of veins that tend to be focally dilated, we would call a varicocele. Now, just to end with a few, if you don't mind the pun, oddball cases. Here we have a patient who has a lot of serpiginous structures coursing within the testis itself. You turn color on. Wouldn't surprise you to note that this is an intratesticular varicocele, has the same clinical implication in some people with associated infertility as the extratesticular varicocele that we just discussed. This is an interesting case on the right side. This patient noted some thick, rubbery consistency around his right testis clinically, which brought him to our ultrasound lab. When you put color on, again, when you just put a clip on and turned up your gain, no color needed here. You can see very, very slow flow on the right side. So what does this turn out to be? That was an acquired right-sided varicocele. And these are, whenever you see a new, particularly on the right side varicocele, you know, this shouldn't happen. You shouldn't have varicoceles on the right very commonly because it's easy to negotiate the flow into the right, from the right into the inferior vena cava. With that new acquired varicocele, we looked up here, and not surprising to us, he had a tumor obstructing the flow, causing that new dilated veins on the right side. What about this case? Somebody shows you this image, you might think there's a mass involving the right testis. But then we went in and we looked at the patient, and I don't see any mass. Looked fine. What was causing this? A finger was palpating the testis. You don't want to take a picture like that because all you can do is cause confusion. That is something that you might want to, anytime I this patient says, I feel a mass, I want to feel it myself, but I don't want to take a picture, which could cause confusion. On the other hand, contrast that to this case where there clearly is a mass in the testis, gradual acoustic shadowing. If I showed you an ovary with a finding like this, you might suggest that was a dermoid or a teratoma, which is what it was surgically. This is an Aunt Minnie. If you look at this case, focus on it, no flow, clip, looks like an onion skin, doesn't it? That's called onion skinning, and that is an Aunt Minnie associated with an epidermoid cyst, a benign condition. Since it has a classic appearance as we see here, this is benign. We took the patient to surgery, helped the surgeon localize it. He shelled it out, and I just show it to you because it does look like an onion skin. What about these couple of last cases? In this case, it looks like apparent enlargement on the right side. Notice microliths on the left. No visible echoes in this. What's going on here? Well, this is bigger than this side. Is bigger better? Well, if you looked at this case, there wasn't really this degree of asymmetry. What this is, I'm sure some of you will know, is a prosthesis. This prosthesis has fluid in it that conducts sound more slowly and more as it goes through the prosthesis more slowly. This is interpreted as a longer distance for the sound to go through, and it causes it to look apparently large. It was not larger. What about this case? This patient on a sagittal scan has what looks like 2 testicles, and as a matter of fact, he had 4 testicles. So he had polyorchidism. This patient, in truth, was a 4-star general. He was very happy when I told him he had 4 testes, 1 for each star on his lapel. He was a very happy person to hear that. It was of no clinical significance. The last case is very interesting and intriguing. As you look at people, you may see people who have, notice the dilated, slightly dilated epididymis in this case, and if you cone down on it, you can see movement within the dilated epididymis. And in this case, this was a patient who actually had lived in India, and this was filariasis. But I'll show you a case that was done at the Brigham Hospital where until recently I was working, and this patient had never traveled, and this is not filariasis. I'm going to say, what is it? We don't know for sure, but most of these people, almost exclusively, had vasectomies. I know Mary Frades, who works at the Brigham, has recently looked at this, and she calls these dancing sperm. I don't know if you want to call it that because sperm are really too small to see, but these are concretions that are moving within dilated tubules and are probably of no significance, especially if somebody's had a vasectomy. So I will thank Dr. Netter and others who I've taken their artwork from, and thank you for your attention. And I hope this has put your mind more at ease into when to worry when you're doing testicular ultrasound.